and ready to go.
All right. Good evening, everyone. I'm Patty Silva, Chair of the Council, and welcome, everybody. Calling this meeting to order. It is 5:04 p.m. and it's October 17th, 2024. First order of business is opportunity for public participation. Is there anybody from the public who would like to say a few words? Okay, there being none, we'll move on. Our first item for topics for discussion, just a reminder that the September meeting draft transcript video are all available on the DDS website under the DDS Council portion. And that there is a live link on our agendas to get there. So just a little easy way to move on over there if you want to check things out. And that's where they'll always be every month. So just trying to give everybody a reminder because things are still a little bit new. So next on our agenda, we have Joshua Scalora here to do a presentation on the Pulse Light demo, which we are all very interested in hearing about. So Josh, why don't you go ahead and introduce yourself? And I believe you have some other staff here with you as well. We'd love to get to know who they are and very interested in hearing what you have to say. Thank you.
Thank you. That's wonderful. Thank you for inviting me. Thank you to everyone here and Commissioner Chef, and thanks to Malika Tanki and Murali Pillai for joining from the Pulse Light team. And they are with the company that developed the Pulse Light Aura application. So that's great. You have one of the local subject matter experts here. That's me. My team uses the Pulse Light application, and I'm going to talk to you about that today. But we also have experts from the team that developed the application. So Malika, would you like to introduce yourself?
Oh, yes. Hi. Thank you. My name is Malika. Thank you. I'm with Pulse Light, and I work a lot on the product side of things. So I'm excited to kind of hear what you guys think about this, but really I'm more here to just see how these DD Council meetings go and kind of hear what people are saying and what are the issues going on. So thank you for having me. I appreciate it.
Thank you. And also, Murali, would you like to say hello?
Sure. Good afternoon, everybody. I'm Murali Pillai, newest member of Pulse Light, but been working with home and community-based services and LTSS programs probably since about 2004 in a variety of capacities across the country. So happy to participate and listen in, and eager to learn more about what the council's focused on here in Connecticut. Thank you.
Thank you. Before I start, would Commissioner Chef like to say anything? He's been a pivotal part in the creation of what you're about to see. So he may have something just to cue me up here.
So since we have some relatively newer members to the council who haven't heard my story on this, I'm going to try and do it in under a minute. So a number of years ago, we faced inspection from the Office Inspector General following a Hartford Current centerfold article on undetected abuse and neglect or unreported abuse and neglect. And it started a cascade of events. And after several years of OIG audit, we were in the needing to figure out a way that we could track unreported incidents and try and learn to identify them. And what we were able to do is Pulse Light was already engaged on waste, fraud, and abuse prevention at DSS, more on the financial side of things. And we were looking to take their work and shape it for our needs. And I went to a demo where they had used a whole bunch of Medicaid data points to help run what now looks like a rudimentary slide and provide some information. And it was pretty startling because what I realized was that I lost a lot of sleep over knowing that there were things I didn't know. And then I saw the presentation from them, and I realized some of the things that kept me up at night I could know about if I had a way to use that data to inform me, to inform the department, to inform providers about issues. And it has since grown far beyond the scope of the original ask. And our partnership with Pulse Light has grown, and we have a very close partnership. But Josh and Malika and others spend a lot of time figuring out what could we add, what else do we need to know that we don't know. Along the route, um, uh, uh, their founder and I had a conversation about how they might improve the work they do. And Irene's not with us tonight, but I suggested that they come out and visit site locations and see what a day program looks like, and see what a residential program looks like, see what an institutional setting looks like, so they could ground some of their data science and IT work in the very nature of the work that we do. And I think that they found that really beneficial. They can now see the impact. They can see the people. They can relate diagnostic codes to people's lives, and why this work has become so important. And I'm going to get off my Pulse Light bandwagon in a second and turn it back to you, Josh. It's also very interesting because it's a woman-owned, woman-founded, minority-owned company. And Malika, I think you're also vice president in addition to your other hats, or a title, something like that.
Yes, Vice
Yeah.
President of Product Strategy, I think.
Which is just terrific. So we've had a long-term partnership, and Irene and I like to leave Josh and Malika alone to conjure up new asks of the data, and to have it tell more stories, and they do a phenomenal job. And I'm hoping you'll get a glimpse into that in the presentation they're going to do now. And thank you for the opportunity to tee that up, Josh.
Thank you so much, Commissioner Chef. And I would just like to say, yes, the Pulse Light team has walked with us. You know, we've spent probably hundreds of hours now. It's been several years, and we did product development together, really. And then we've been using the tool and continue to meet with the team on a pretty much a weekly basis. We continue to work on improving the product that I'm about to share with you. And what I want you to know is that it's not done. So, and a lot of the new capabilities that we've gotten through the use of what we'll refer to as Aura, they're new for us as well. So we're learning new ways to use this information. And without further ado, I'll start the presentation. I believe that I have about 15 minutes of presentation, and that I expect there might be some discussion afterwards. And I also like to say thank you for inviting me. And this is my first discussion with you about this, but it doesn't have to be the last. So there might be things like follow-up info you would like, or questions, or further information we can dive into in another visit. All right, thank you so much. With that, I'm going to start sharing my screen. I'll look for confirmation, verbal confirmation that people can see my screen. All right,
Yes.
and visual, I got both. Okay, and now I'm going full screen. All right, excellent. So we're going to talk about how powerful technology that Pulse Light developed helps Connecticut DDS enhance the quality of care for individuals. We'll talk a little bit about what the catalyst was. I think Commissioner Chef really summarized it perfectly. We'll revisit that a little bit, how we kind of got started, and what we call the automatic ingest and analysis of claims. And that means that there's a bunch of data that's getting sent to Pulse Light from different sources, and they're taking it in their tool and analyzing it for us, and then feeding it back to us as analyzed data. We'll talk about how we're using it to help people today, and then how else we could use it. What are some other things that we could do? I can't monitor anything other than looking at the full screen. So if anyone, if anything comes up in the chat, or if there's a hand up or anything, if someone could help with that, thank you so much.
I'll help you with that, Josh.
I'm sorry, Wes, I'm stepping on your words, but I think Malika may want to hear this. Adriana Ramirez is one of our council members and the president of Connecticut Family Support Network as well. And she used a phrase, humanize the data, and I think Irene may want to hear that at some point.
Yes, I think so. I think it's been an amazing journey for us with this technology provider, for them learning about our culture and the care that we have for individuals and how intentional we really needed to be to use data to find these potentially unreported incidents and do something with it. So it's been a great journey with them as well. What got us here? What was the catalyst? Commissioner Chef talked about the OIG audit. We're not here to talk about the intricacies of the settings rule, the joint report, or the access rule, but they are influential on this discussion. The settings rule was a change in the quality framework for the Medicaid waiver system, and it introduced some specific new reporting requirements around critical incidents. There were 3 audits here, Connecticut, Mass, and Maine. And then a joint report was issued with findings and recommendations for using claims to find unreported incidents. That is the methodology that was utilized in the audit. The Office of Inspector General received a list of individuals that lived in DDS supported locations for a time period, and then they went to Department of Social Services and from their Medicaid data warehouse got claims, the full claim set for those individuals with those Medicaid numbers, Medicaid IDs for that time period. And they did a gap analysis. They found things that were an emergency room visit or a hospital visit or admission even that looked like it met our requirement for being reported to us. And then they asked us to produce the report that should have accompanied that. And in some cases, we weren't able to. And that's really where we started to realize there's obviously so much more to the picture than what people tell us about. But if we only know what people tell us about, we'll never know the full picture. And we knew we needed to do more. There were several other audits, as you can see, that led to a lot more learning from the U.S. Office of Inspector General, but also CMS. They're not the same organization. They're 2 different federal orgs, but they work closely together, and they're both interested in this issue. And they've issued the joint report as a group of federal agencies. And a lot of the findings and learning that the federal government has done in the interim has led to the access rule. And the access rule is the next iteration of the waiver quality framework revision. And it updates definitions of critical incidents across all waiver types, not only waivers for people with intellectual disabilities, but every single Medicaid waiver type. It creates one national standard. It's a minimum standard that can be layered on and enhanced by states, and it's expected to be added to. But at a minimum, the new standard in the future will be a critical incident is an incident where there is suspicion or reasonable suspicion of abuse, neglect, or exploitation. So we had these findings that led to us realizing that we needed to use Medicaid claims to find unreported incidents, and we tried to do it ourselves. It was really challenging. While we were working on that, we learned, as Commissioner Chef mentioned, that our Department of Social Services in Connecticut had partnered with the company PulseLight to develop software to help detect fraud, waste, and abuse in the Medicaid claims. And functionally, what that meant is that PulseLight, an external company and a cloud-based company, was getting the full Medicaid claim set from Connecticut already. And our data was within the data that they already were getting. So that posed a unique opportunity to leverage a solution that was built around a data set and update the rules, et cetera, to instead find fraudulent billing, now find potential unreported incidents. while we were doing that, we were trying very hard to use that same data to find these things, but we just found too many. That was the problem. We didn't have a way to wade through all the data to organize it and prioritize it. And there are so many lines of data that we were asked to print 6 months worth of data and bring it to a meeting. And we really questioned the value of turning the electronic, Excel documents into paper, but we were vehemently told do it, and it was about 500 pages. So I like to joke that I'm the director of business intelligence, and that was like the opposite of that. It was almost impossible to use. And when we did get a demo from PulseLight, the demonstration showed us some things really quickly. It showed us a pattern of injuries. And although the data in the system, let's say all of the details were changed other than the claim code types, the data was based on real data, and the data was recognizable to us. It was related to an accident, a vehicle accident, and it was incredibly impactful for us to see that this tool worked to show us something that we knew about and we could identify it. This tool could show us that vehicle accident with a cluster of injuries and severe injuries. This tool could help us see things that we would only know about if people told us about them. So it was really a powerful observation for us. And we realized that the claims data could be mined to find unreported incidents and allow follow-up and resolution. So we talked about PulseLight. Commissioner Chef mentioned that PulseLight's a woman-owned business, and the business is really organized around helping health and human service agencies improve health and safety and outcomes for individuals, and enhancing person-centered care, quality, health equity, incident and abuse, neglect, and exploitation detection, management, and prevention. And the Aura tool that was developed after our initial incident reporting tool really puts a 360-degree view around the person and gives some amazing new capabilities to us that we'll talk about in a moment. But first of all, what types of claims are available for analysis in Aura? We talk a lot about claims, and they're not all one thing, but basically these are bills for services that were Medicaid billable services, and these are Medicaid claims primarily. These are professional claims for services by medical professionals, institutional claims, so things that like might be billed at a SNF or something like that, a certified nursing facility, pharmacy claims, or things like durable medical equipment, dental claims. That is a major indicator. Restorative dental can be a major indicator of abuse, as can extractions be an indicator of neglect sometimes. So there's different uses for that dental claims, and there are different indicators for what that data may mean for the individuals who are experiencing it. And then there's also these services by federally qualified health centers. Those are the different types of claims. And when we look at and think about the data, first of all, I want to give all credit to slides, and I know it's on the screen, but PulseLight developed this deck, and they are better at it than me. So if there's fancy stuff that you see, they did it. Thank you for helping with that, and it is a partnership, really. But starting with Medicaid claims, we also bring in agency data. So that would be data around the individuals who are on the Medicaid waivers and receive waiver supports out of our data system, including placements, the services that individuals get, the providers that support them. There's a unique identifier in our data system called an RDID. It's a residential and day ID. It's alphanumeric, and it has unique identifiers for things that like tells them if it's public or private, if it's res or day. And then those are also tied to location-based services, so we can organize things around that. And in addition to that, we're pulling in incident reporting data, critical incident, restraint, med error, allegations of abuse, neglect, and other data which we'll dive into. But there's a lot of other different types of data that can be joined with that. And we're not joining with all of those types of data, but I do want to call that out. Some examples might be needs assessment, Medicare, which is a high priority for Commissioner Chef, and we're going to be working with our with DSS on gaining access to that information in the future. ADT, admit, discharge, transfer, which we'll talk a little bit about. Medicaid Fraud Control Unit. These are a lot of acronyms. I'll keep going though, just reading them out. Adult Protective Services, Child Protective Services, Substance Abuse Prevention, grievance systems, electronic visit verification, and waitlist systems. Some states join their different elements of these systems in combination with Aura to provide a more nuanced view of the information in the individual provider and service locations. And this information is useful not just to people that are supporting individuals with intellectual and developmental disabilities, but all long-term services and supports, mental health, aging, regulatory, and money follows the person. And in general, it can be either a single or multi-agency program, for example. Some states have one Health and Human Service agency. That's not atypical. That's kind of the norm, and we're also the norm. I don't know if it's 50-50. Commissioner Chef probably knows better, but you know, in some states, if they're using Aura, they might be using it across the Health and Human Services sphere. And in Connecticut, there's a couple of the agencies are using it now. There's some additional growth beyond DSS and DDS. And I know we have a vision to share the insights that we get from the Aura system with others so that they may benefit as well. So we started using Aura to conduct a monthly review where we basically run reports that detect critical incidents for DDS individuals for a time period. Like I said, we do it every month. We've been doing it for several years now. And when we detect critical incidents, what that means is we get a report in the Pulse Light Aura system, and it has data that is information about experiences that people had around medical treatments. And we've worked with PulseLight and their team to tailor the claims that are used to detect these things and show them to us to our incident and critical incident procedure. So they're showing us things that our procedure says that we should be looking at that should be reported to us, and things that are, those are the detected critical incidents. We review those every month, and there's a interdisciplinary team that reviews that information, does research to triage, to identify if we knew about it, but it just wasn't entered into our data system. If, for instance, is there a case note about it? Was the case manager informed? Was the health services director informed? Did the right people know about this thing, or was there an allegation of and investigation of abuse or neglect? So we're already sending that information, but we also do an additional check to say, did we miss anything in the algorithm? Were there things that were outside the date range that look like they might line up? So we do an additional review to see if we can find any more information. And then there's a follow-up process to ensure proper reporting and resolution, and the follow-up can occur. Specifically for critical incidents, there's a number of things per procedure that are supposed to happen. The reason the procedure requires those things to happen is that they make sure that the team is aware of what occurred, and that there's that they're able to do preventative measures if necessary. But after we started using it, it's very effective, and we're able to do follow-up with providers and ensure that the team is informed and that all the right people know about something that happened. We're seeing better reporting in our system, a better knowledge of the reporting requirements because we're shedding more light on the system as a whole. But in general, there was some information lacking, and a couple of the things that we were missing that we really wanted to um, add to the system was level of need. The people at DDS that use the tool to review these incidents often are going back and forth between the level of need application and the pulse light application to verify what the person's level of supervision was, or if they had a choking event, do they have dysphagia, or is there some other thing like another part of their diagnosis or a risk factor from the individual's level of need assessment that would explain what occurred or be relevant to the situation. Specifically for supervision, that is something that is looked at very, very closely whenever there's an adverse event specifically in provider operated locations. We're looking to see, did the person have enhanced supervision? Did they have some sort of protocol or plan in place to prevent whatever did occur from occurring, and then maybe a system broke down? So we're really trying to do preventative measures as well. And we also wanted to gain information faster. So it was a long time goal of Commissioner Chefs to add admit, discharge, and transfer information. I don't know if anyone's heard of that before, but that is information that health providers like medical systems and hospitals send to the state's health information exchange when someone is admitted, discharged, or transferred from a hospital or an emergency room. And that is for all emergency rooms in the state of Connecticut. All are supposed to send that information to Connie, that's the state's health information exchange. And what we wanted to do was see if we could get an early warning system. The claims are amazing, but there's a time delay in claims. So the claim is based on that service being provided and then the bill being submitted. And we send data every 2 weeks to PulseLight, and DSS sends data every 2 weeks, but claims can be 30 or even 60 days in arrears. So you can see that that helps us find important to know information, but there's a little time delay. So how could we find out things faster? We wanted to add admit, discharge, and transfer. That's the early warning system, the thing that tells us something bad happened right away. And by getting that information, we're hoping to be able to create a system where we're reaching out more sooner and we're able to prevent less unmatched detected critical incidents down the road. For instance, a lot of the things that we find, 2 months later, if we knew about it now, we could ask for that incident report this week and maybe get it next week, and it wouldn't be late. The team would know about it in time. So we're really shifting our focus to see if we can learn about the admit, discharge, and use that admit, discharge, and transfer information to do interventions more quickly. And we also added emergency room analysis to the tool this year. So those tools have been incredibly impactful. But beyond the tools that DDS uses, PulseLight created a new version of their application, which we benefited from. This is beyond our original use, and that's Aura. This is something that DDS is very excited about, and I think others are as well, because it's created a real expanded view of information. It helps us see provider performance, gives us a view into health equity, gives us a lens into the fatal 5+ conditions for individuals. Other adverse conditions like diabetes and heart disease, we can track care, drug utilization, service utilization, and analysis. How am I doing on time, Commissioner? Is the pace okay?
Yeah, we're at 5:30 now. How many more slides do you have?
Just a few more slides.
Okay. Yeah, if you can
So-
get that's great, because I'm getting, I know people will have questions, so.
Yeah, and I think you're just going to see more of what I've already talked about. So I'll definitely summarize these slides pretty quickly. I wanted to show that, thank you. I wanted to show that in the area of critical incidents, we talked about how we're using the tool for these unreported incident detection and to ensure that there's resolution. We're also able to see risk factors, use the tool as part of conducting an investigation, or conduct the outreach to the provider to ensure proper reporting. Gives us new management and oversight tools as well, new views into fiscal impact of our investment in resources. We can see the Medicaid spends, and we can eventually tie those spends potentially to outcomes. We haven't developed that framework, but we have the capacity within this tool to do so. The ability to use this information as inputs to our DDS overall provider performance and quality assurance process. There may be some providers on the meeting, if people are familiar with the DDS provider performance review process. There's a large set of information and data that's reviewed with providers every year. And the people that design those tools are looking at incorporating some of this information to be able to provide additional feedback to providers about how well they're possibly doing with reporting information to us or supporting individuals' access to healthcare. We have new health equity tools, and those give us the ability to kind of slice and dice these outcomes that we've been talking about by race, ethnicity, language, and other factors such as age or gender, sex. And also the ability to automate policy and audit compliance. For instance, if we get a new rule, I mentioned the access rule, which will necessitate DDS to revise our procedures. For incident reporting, we will have a new requirement around critical incident definitions, specifically around suspicion of abuse or neglect. We will be able to work potentially with our partners in PulseLight to change the algorithm, change the things that we're looking at to expand now. We're going to go broader than our current definition of critical incident. We're going to need to come up with new rules, but we'll be able to, once we feel that we've tuned those rules and that we have a good, that we're using the right codes to, that we're providing comprehensive oversight for people, that we'll be able to automate that. And that's a powerful thing across a whole system of care. At the individual level, we're able to provide new views of the person that we haven't had before, that overlay a lot of these metrics that I've been talking about, like detected incidents and reported incidents, abuse and neglect events, Fatal 5 events, polypharmacy, psych hospitalization, and abuse and neglect and exploitation claims. And we're able to see that over time for an individual and see patterns of decline for individuals, and hopefully make sure that the right people have access to that information so they can do something to help that person and improve the situation. So there's a lot of possibility with the new tools that we have. And we're very, very hopeful about new ways that we can use it. These are not your eyes that you think are blurry. This is just some proprietary slides of PulseLights. So we're not able to show these screens at this time, but we are excited to find ways to show you the outputs from our system. If we can't exactly show you the screens themselves at this time, I'd be happy to come back and share some metrics around our use of the tools and some of the outcomes. So these tools show us visually individuals' history over time, and they can overlay those things that I was talking about and then be expanded to show the details. So we can actually see the details of what that incident report said when it was reported to us, and we can read the details of that medical treatment, and we can read what that abuse neglect allegation said, all in one place. Very, very powerful for us. We use it for the periodic and detection of the unreported incidents and to trend analysis, to do trend analysis, looking for patterns that might lead to an intervention, like a pattern of non-reporting for a provider or a provider location. Right now, we're really diving into the review of emergency room and the inpatient visits, trying to look for those early warning signs of the critical incidents or other events. And that's what I was kind of just talking about with the admit, discharge, and transfer data. But how else could we use Aura to help people in the future? So right now, Pulse Light is engaging in a series of trainings for DDS staff, and they're pretty expansive in terms of availability. We cast a broad net, and we're really training a diverse group of people from across our system in access to this information, but really focusing a lot on healthcare, investigations folks, the quality, licensing, QSR, healthcare, and the clinical folks. The clinical staff in the regions are some of our most avid new users. We also partnered with our Director of Equity and Inclusion, Dr. Cheryl Ellis, and Dr. Ellis is starting to use the equity analysis tools to conduct her own analysis for DDS based on some hypotheses that she has. So it's becoming more broadly utilized by DDS, and we're expanding our bench of individuals who can use this information. Pulse Light's also in between the trainings offers office hours, and those office hours give the opportunity for DDS staff to bring their ideas and questions, problems and needs around the use of this information to the Pulse Light team and have that team work to solve that for them at that time. From my perspective, the analysis of the trends and patterns across the fatal five and the adverse conditions is probably one of the most insightful tools that I've ever seen in data. And I think we're really just starting to scratch the surface with our use of these tools. But these tools were developed, at least from our perspective, by the necessity to utilize claims to better understand the individuals that we support, to make sure that when people are supposed to report things to us, that that's happening, and when follow-up is supposed to occur for things like critical incidents that are very severe, that that does occur, because that allows the prevention of a preventable event from that allows us to try to prevent that from occurring again, and also learn at a system level. So I'm really happy to have been invited here today by you. I appreciate having the time. You gave me a lot of time. I sometimes talk a lot more than I mean to, so it's tough to sum it all up. I could probably talk for a couple of days about these tools that we're using, and I'm not sure I gave you the information that's the thing that's most important to you. So I don't know how much more time you all have for the discussion, but if you want
Thanks,
to
Josh.
take over.
Yeah, I'm just going to step in. Jordan Chef, Commissioner DDS. So first of all, thank you. I think in what Josh shared is an important detail I just want to highlight. We went from looking at a tool that would help us do a look back at what was missed. And while we still value and use that part of the tool, we've really pivoted to being able to look forward towards prevention and identification of concerns that don't need health outcomes that don't need to happen if we can get involved early enough when we see things. So while we'll use it for the original intent, it does continue to morph and grow, and not just for us. Well, the work that Josh has done, other states that Josh and Pulse Light have done, has been adopted in other states who also had really good ideas about how they may leverage the tool further. And so we reap the benefits of the enhancements very often made for other states that also work for us. And it's, there's a resource issue in terms of how staff can save a lot of time from going out and doing paper audits of certain things versus having the data presented to them in a digestible format at their desk. So our licensors, instead of spending a day flipping through page by page in a book, they can spend an hour the day before prepping for a licensing visit and have a lot more time outside of the book to be helping us on our licensing and quality visits, the amount of time in travel, the number of people we send to a visit, with a limited number of nurses, we can really leverage that during the nursing and other staffing shortages. So I'd like if the council has any questions for Marlai, Malika, or Josh, to go ahead and fire away, if that's all right with you, Patty. And I think Patty's been having some trouble getting bounced off and on and has been polite about it. So I don't know if you're on, Patty, at the moment. So with her not present at the moment and having some difficulties, or at least not able to speak at the moment.
Commissioner, she is. She just probably is on your other screen.
Okay. She may be. There she is, but she's muted and she can't talk. I see her lips moving. Okay, so we're going to work on that. Are you okay if I sort of facilitate questioning? She's nodding along with me. So anybody have any questions for the team? I'm not seeing any. Oh, Deirdre?
Yeah, hi, I'm Deidre Toole, counsel. This is all new information for me, so it's a lot of acronyms and a lot of new different departments, et cetera. But I find it really fascinating. It seems incredible we can be doing all this to help identify individuals at risk. My question is what ages are we starting with identifying individuals and looking at their history? Are we going back to birth and the history of DCF in their lives? I didn't know like how early this, how far back we're going. Are we looking at during their school age time, or looking at 18 and up only? I just didn't know what the age group was for this.
No, there isn't like an age cutoff. It's people that we have the authority to look at. So if it's someone that's in a DDS waiver, they're enrolled on a DDS waiver, getting a DDS residential service on the DDS waiver, we're looking at them. We're not going backwards and doing like life history reviews or anything like that. But we have data from the person's Medicaid enrollment from 2015, I believe, in our system. Yeah, but we don't go back and replenish that data. So, you know, we, as new people come into our system, they're in our system and they're always in the Medicaid system at DSS. So we match our people up with their people, and that's how we use that data.
So I just, because I work in a school system, I think from birth to 22, the incidence of DCF in some of my individuals' lives and what's been happening with them medically, and also use neglect, it seems like it would be an important piece of data to follow up on at some point.
Yeah, so DCF is not Medicaid funded. And so the Commissioner Chef is very interested. I'll just say, I know Commissioner Chef is interested in sharing the good news of what he's been able to learn by using this information with his colleagues at other agencies.
We are we are working hard to ask our sister agencies involved in the Medicaid space, so DMIS, DSS, potentially DCF, because a number of their kids do get Medicaid, but any of our partners, Birth to Three or Office of Early Childhood, we think if their Medicaid dollars are spent on them and we have Medicaid data that can help us learn something, I personally believe we should be harnessing that. For dozens and dozens of years, states in the country sat on piles of data that could really inform a better outcome and a better lives for folks, without any real ability to do much with it, because it's mountainous. And I don't know, Malika, if you have any idea in the state of Connecticut how many data points we're talking about that you've ingested, but you have a
over
ballpark?
a billion. I think we have over a billion records now. That's for all of Medicaid, though. For your population, it's significantly smaller, but it's a lot.
And that's for Connecticut, right?
Yep.
So every state has Medicaid data, and it just sits in stacks in drawers, and no one was harnessing it. And now we can. And to have that's my point. If you can have information that can help you do a better job at your fingertips, it's right there at your fingertips. No one has to do a desk audit. It's pretty powerful. For me, if I could go back 30 years and have access to this data, oh my God, the things I might have prevented, and the things we're preventing now. Josh has a staff that works for him. So in addition to some of the other people who are starting to get involved, we review cases weekly and we are routinely, and we have found some things. We have found some curious things in the data that made us go back and ask a question that led to a better outcome for an individual. I know of that particular story because I heard it directly. I know that that story occurs over and over and over now, and it did not occur 3 years ago. We didn't know how to do that. We couldn't do that. We had no eyes on that data. So to me, if we, it's like that starfish sort of poem, right? If you, it may not matter to all the starfish, but it matters to that one. If we can help one person have a better life through harnessing that data, it's incumbent upon us to do so. And that's my message to my colleagues when I talk about this. Adrian,
Oh, yes, am I on? Hi, hello,
Your
Adrienne
mic-
Benjamin, council member. Two questions. First of all, this is amazing, and I'm really impressed. And when I heard there was a presentation about Pulse Light, I thought, what is that? But now I know, so thank you. Two questions. One is for someone that has both private insurance and Medicaid, at least my own personal situation with my daughter, she has private insurance and Medicaid. So private insurance is billed first. Do you get
Right.
that data?
We
No.
can't get the private through
Yes.
through Medicaid. We don't get private through Medicaid. That's right. So I won't get into it too much, but there's another supplemental data source that we're getting the ADT data from, the admit discharge transfer. That's Connie. It's the state's health information exchange.
Oh, yes.
Too many.
I know
It's
about
another.
Con-
It's an. I know.
I know
Next
about
time
Con-
I'll bring a diagram. I know.
Don't.
I apologize. But basically, if our medical information in the state of Connecticut goes into an electronic health record system, it's
Mhm.
supposed to get transferred to the health information exchange. And that's all medical, no matter private, whoever pays, all payers, right? So we maybe in the future be able to bring that in, but right now through the authority that we have to access information, we don't have access to that.
Okay.
we are in pursuit of Medicare data because about 40% of our population is duly enrolled in Medicaid and Medicare. So we're in the process of trying to incorporate that. Pennsylvania's going to beat us to the punch. They may have already done it, and I'll be jealous of Kristen and her team there for pushing that with their Medicaid organization. But we're on the way.
And I have to say, I have to apologize. I do have to run, but I might be able to stay for your last question. Just there may be more questions that if it's okay, I'll be happy to follow up with you on.
Yep. Was there one more,
Wonderful.
Adrian?
No,
No,
okay.
you're good right now.
Thank
All
you
right.
so much.
Thanks, Josh. Thanks, Malika. And I lost him. Malai.
Morale, he's there.
Oh, there he is. He's next to Malika. You moved around during the presentation. Thank you for attending. I'm sure that we'll have other opportunities to talk about this more, but I want to thank Josh. He gives me a lot of credit for leadership on this, but we have Josh has been pushing this just gentle, steady pressure for a number of years, and it's one of those things that's hard to see how it's going to pay off because you're in the weeds of it, and he's been deeply in the weeds. But we have pushed and pushed and pushed, and we're realizing outcomes. I think for our friends at the Office of the Inspector General, they certainly would have liked us to go faster, but I think given the way the new rule from CMS, the access rule is written, indicates to us that they like what we've done and they'd like more states to do something like what we've done. They're going to set the floor. This product will go far beyond the floor, but we think that we have led here pretty strongly and recognized for the work. We could have just made an Excel and Access thing that was 500 pages long and sat somebody in a corner to pour through it and see if they saw anything interesting. And as my friend John Martin, who's also looked into this product quite a bit, says, just because it's interesting doesn't mean it's important. What we can learn here is that the things, I use that all the time to reframe because I go down rabbit holes,
Yeah.
right? It's interesting, but is
Me
it
too.
important? Let's move on to the next thing. So Josh and I think about that phrase from John often, but it helps us see what's important. And right away, it pops. Christina Latimer, who didn't join us tonight for the presentation, works for Josh, and she is rifling through incidents at a rate we never could have done follow-up before. And we're going to get to automated push notifications, and there's more and more to come. But thank you to the team. Thank you to our friends at Pulse Light, Nora, and to you, Josh, for showing up and sharing tonight. I appreciate you.
Thanks so much, everyone. Have a great evening. Take care.
Thanks so much.
Bye.
All right, Patty Silva, Council Chair. Can everybody hear me?
Yes, we can.
I know, but I can't push any of the buttons. I can't mute, I can't whatever. So, but okay. That was great. Thank you, Jordan, for arranging that. That was so interesting. Of course, 1,000,000,001 questions, but great presentation.
Thank you.
Next item on our agenda is the ombudsperson report. Shannon, you are up.
Hi, everyone. This is Shannon Giacovino, DDS ombudsperson. I did send out my written report yesterday. I didn't receive any questions from anybody or any particular issues people wanted me to address. I will say that it was a month that was maybe somewhat less busy than the past few months have been. I'm not quite sure why that is, but somewhat fewer contacts. I didn't notice any particular trends this month, except, the one that I've been talking to you about for the past 3 years, which is that, the staffing crisis is really having an impact on just about every aspect of people's services and their lives. And most of the calls that I get in some way sort of relate back to the staffing crisis. So I did want to make everyone aware that, their Public Act 23-137 was passed in the 2023 legislative session. And there are going to be a lot of the reports that were included in that bill, including the report that addresses the career pipeline, are going to be coming due and are going to be part of the discussion this year in the legislature. And I think it's really important for all of you and individuals and families to make sure that you're a part of those discussions, because I can't think of a more important issue for people to be addressing. I think Josh talked a little bit about the fact that I am seeing an increase in the calls that I'm getting around people who are in emergency rooms. The hospitals are very anxious to move people along. In many cases, there's really not any place for people to go. They can't return back to their home. They can't return back to the program that they're in. I think DDS is doing what they can to try to manage this. But I think with all of these issues, I think DDS has been very responsive, but I don't think that these are necessarily issues that our DDS is to solve alone. Yeah, I would just encourage you to all stay aware and to really be paying attention next legislative session, because all of these issues are going to be discussed. And it is just so critical for people in our community to be talking about how this is impacting them. Does anybody have any? Oh, Adrian.
Hi, thank you. Adrian Benjamin, council member. I'm going to give a little shout out to the agency my daughter's involved with, which is called HARC. And I'm not saying it's a perfect agency, but they made the decision a few months ago to raise the wages, even though that raise did not come from the state. So the wages are now $19 an hour for people in group homes and $18.50 for day programs. What has happened is that their vacancy rate for staff went from like 45% to 8%. They've hired so many people. They also increased something in their I guess the health benefits. I don't know exactly what the details of that. But, I remember hear people saying, well, there's just people that don't want to work in this field. And obviously that's true. But raising wages helps. And we should get the word out to the agencies we're involved with that if they can do that or work hard to figure out a way to do that, it will help it's not, obviously, is that a livable wage in Connecticut? Nope. Does that mean nobody else is going to, that they're not going to have a second job or a part-time job? But it's progress, and it's really shown up in the staffing. So that's my message.
Thanks. Mike Beloff?
Michael Beloff, council member. And Shannon, I just want to make sure, just had a quick question about your role. Sometimes when I get weird questions, people will say something, they're having an issue or with applying or appealing, and I just send them to you. I just want to make sure that's the proper, that I'm not overburdening you when people have questions in that way.
Yeah.
That was the first question. And the other was, and this may be more for the end. I know one of the big reports that's being done is, doing the research into whether IQ should be part of intellectual disability. And I was wondering if there's going to be a point where we're going to get an update on preliminary findings or what might be in that report or what that looks like.
Sure. So this is Shannon Giacovino, DDS ombudsperson. So for the first part of your question, send people my way. I mean, that's what I'm here for. And if they're having a hard time figuring something out and they're coming to you, then the chances are that even if I don't know the answer, it's going to be a lot easier for me to get that figured out for them than it is if they continue to try to grapple with that on their own. So absolutely, you're never bothering me by sending people my way. You're helping me to earn my pay. As far as the other question, I know that OPM is responsible for the report on the potentially changing the definition. I know that they're working on the report. I was a part of a work group that reviewed. They hired a consultant to come in and sort of do a review of what's happening in other states, and just sort of try to outline all of the options for Connecticut. I don't know when that report will be released, but I know that it should be soon. I think the due date has come and gone, but there was an extension on that. When it will be made public or how it will be made public, I don't know. But I'm guessing you'll be privy to that information as soon as it's able to be made public, because a lot of people are waiting to hear that information.
I think originally the report was due in January, so I know it's not. I don't think it's due yet for that particular item. But of course, my concern is that they always is if the definition is changed and more money is not given to DDS, that can cause problems as well.
Right. Well, I guess I would say that changing the definition, we don't know what the impact of that would be on DDS or, where services, like there's a lot more to that issue than just money. And so I think that when the report is released, I'm sure that there's going to be discussions about that in the legislature. And those are the areas where I think it's really important for people to be paying attention and to be taking advantage of the opportunity to provide your own input on those issues. So I think you'll have those opportunities. Kevin Bronson saying the due date is January 1st, 2025. My apologies. I thought they asked for an extension on that one.
Addie Silva, Council Chair. Does anyone have any other questions for Shannon? Okay, we'll move along. Thank you, Shannon.
No problem.
Next up is Commissioner.
Hey, Jordan Sheff, Commissioner DDS. Our friends from Pulse Light Aura, looking always to learn more about what they can learn, have asked if they could stay on. And of course, as a public meeting, I welcome them, and as valued partners, I welcome them as well. They can gain some insight. So thank you for sticking around, both of you. One of the things I wanted to make sure on the Pulse Light presentation that was clear that the a slicer dicer, which is hard to visualize in the blurred images because we weren't able to de-identify it in a way that would make it shareable, and it's also proprietary to PulseLight in a public-facing meeting. So there's a number of reasons that's obscured that way, but that we can look at trends by person, by location, a single group home, by an agency. We can also do it by zip code. And there's a number of things. And, we looked at some of the most recent data, and I looked at claims, and I could drill down on a person who I used to support in private sector. And I could see a history that was just so valuable to see her progression as she aged and why certain resources were needed. And, I could see a lot just from the claims data and getting to understand a little bit better about where she's at. That's incredibly valuable to my boots on the ground staff who are trying to balance resources. There's also another point we didn't highlight much, but I think is important to note in what was shared, is we've always looked at how we fund individuals in a vacuum. What is DDS funding? This allows us to see a total Medicaid spend on an individual across multiple settings. So if you have someone who has in-home supports, less than 24-hour supports, and attends a day program, there's a lot you may not know about them. And we make decisions on what we agree to fund based on just that. But now that we can see medical history and other events in their lives through Medicaid claiming, we get a better picture. And sometimes I think our partnership with DSS on this is important because one of us is going to pay one way or the other for a person's needs. And we were making those decisions not knowing what the rest of Medicaid may be spending on an individual. And now we can really look at it holistically and ensure that we're not being penny wise and pound foolish when we can pull members from those other agencies together to say, listen, this person has an unmet need. What's the best way to go about it? You spending the money, us spending the money. It really does, I think, benefit outcomes for individuals. But like Josh, I spend hours talking about PulseLight and can spend hours more just because it's probably the most innovative tool for what we do I've ever seen. So I'm going to shift a little bit to a tool that right now isn't working for a lot of people. Talk a little bit about how I've spent my time this month. Many of you, particularly those of you who spend time with other parents, providers, and others, are aware of the ongoing issues we are having with our fiscal intermediary. We continue to pound through, it affects providers too. We continue to work through those issues in close concert with our partners at DSS, and done a couple things to try and make those outcomes better, including investing in a key staff person to coordinate for us at a statewide level for DDS. Joe Carvalho has come back to DDS specifically right now as a senior consultant to my office, senior policy advisor, spending most of his time right now on GTI related issues, our escalation, daily contact with the vendor. We've also brought in consultancy through Deloitte to assist with trying to mitigate some of the negatives that families are encountering. While I say that, there's a number of people who are thrilled with the product and the way it works, but there are enough people who are unhappy that it's getting its due attention. I don't think it's I don't think it's sensationalized in any way. I think there are true issues, but we continue to work on those. So I spent a lot of the last month focused on that. We are in close concert with the governor's office and OPM as we are formulating the budget that will drop when the governor's ready to share it. And with that, any policy initiatives he plans to include. But we don't have anything to share on that yet because it's all, it isn't publicly yet known information. And that's at when the governor's ready, the governor will share as we get ready to head into session in January. That has been where I've spent a fair amount of my time. I also have had the honor and privilege of visiting a number of locations over the last 4 or 5 weeks, 6 weeks, 7 weeks. It blends together. And for staff recognition, DSP, Direct Support Professional Appreciation in our public sector. I know there were a lot of events in the private sector as well. And today I was at our South Region Staff Recognition event which we held down at Harkness. Rare that we get to gather everyone or most everyone in person to celebrate accomplishments, to commiserate over challenges. And they were able to do that, and I was able to visit with them for a bit, and got to visit with the self-advocate coordinators as well. And a couple of them who I have not seen in some time. So that is how I spent most of the last month. And I'm going to cut myself short there and open it for questions. And I see Kevin's hand is up.
Yeah, thanks, Commissioner Kevin Bronson, DDS. The one thing I just wanted to add to the group was that for the guardians and individuals on this call, you should have received in snail mail a flyer to the upcoming stakeholder forums, which are going to be happening next week. And I'm happy to drop a link in the chat. So just wanted to add that in.
So I'll come up for air there and pause, see if there are any questions that you may have for me before we move on to anything else in the agenda. Did Josh wear you out? Because usually you got all sorts of questions for me, but maybe he wore you out. If that's the case, I'm going to bring them every month. All right, I don't hear any other questions, Patty. Jordan Chef Commissioner, I'll yield back to you.
All right. Patty Silva, Council Chair. Next on our agenda, thank you, Commissioner, is our bylaws. So at last meeting, you guys had the opportunity. I had to bow out early, but I understand that you guys went through the changes in the bylaws, and I haven't heard from anybody that there were any concerns with the updates. So if everybody is in agreement, somebody want to make a motion to adopt the updated bylaws?
So moved.
Okay, Michael, and is there a second?
I see Christine waving her hand. I
Christine.
think that's a second.
Okay,
Whatever.
Christine. So all in favor? Say aye. Aye, okay. Any opposed? Okay, there being none, the motion passes to adopt the amended bylaws. Thank you, everybody. And next up is discussion. I'd like to form a nominating committee for, it's that time of year, for the executive board. It would be for the chair, vice chair, and secretary position. And we usually will vote at our December meeting, I believe it is. So we would need several people to form a nominating committee. And I think usually what they do is try to work together to come up with a list of people to nominate. Sometimes they will talk to people who have been doing it, see if there's an interest in continuing, or if there are people who are interested in jumping in. So if there's anybody that is interested, it's usually, I think, about three or four people. So do we have some volunteers to form a nominating committee? All right, Adrian, Pam.
And Diana.
Pam and Diana.
We're professionals. We've
Sounds
done this
familiar.
before.
Is there anybody else? Okay, wonderful. Thank you, ladies. So you guys know your job, so I'll leave it in your very capable hands. Thank you so much. And then Christine, you had something very quickly. To deviate just very, very quickly from our agenda about transportation.
It's Christine Hainsworth Strauss, council member. Yes, you haven't heard from me yet tonight. Aren't you surprised? But quickly, the transportation committee, after a year, we have a meeting. And they're apparently, thank you to Kevin. I can't see your little square, Kevin, but I know you're there. Thank you for helping. They're having an open forum that is, I guess, being run by the hired contractor for the DOT to speak to issues, to get information about what the issues might be within our community. And it's October 28th from 10 to 12 a.m. or a second session, October 29th, 6:30 to 8:30 p.m. I could forward the link to Wes if she could send it out to everybody, because it's not something I can call out and I can't find it anywhere else. So please send out to anybody else that you think might have transportation issues or suggestions or things that we can improve for our community. Thank you so much.
Great. Thank you, Christine. Patty Silva, Council Chair. And next on our agenda is the November joint meeting with the RACs. That's a meeting that we do every year, and we invite the regional advisory councils to attend. And typically, is it regional directors, or if the directors aren't available, it might be the RAC chairs that will give a report on what's been going on in their regions, that sort of thing. Is that correct, Jordan?
Jordan, Chef Commissioner, DDS. Yeah, I believe that is correct.
Yep. And we also will, Jordan, you said you were going to do something about the wait list, correct?
Yeah, the statute on the joint meeting asks me to report out on the wait list once annually to a joint meeting of the RACs and council, and that is what we will do.
Right. And then once we're done with that portion of the meeting, then we go into our regular meeting. And if the people from the RACs want to stay on as members of the public, they can do that as well. So so that is really what the joint meeting is about, and hope everybody will be able to attend. It's nice to see what's happening around the state and get to know some of the people who were involved in the other areas. So then the last thing I had was I was working on trying to update my member directory, and this one goes back pretty far. And I wanted to just get a feel for how you guys thought about sharing your information as far as like a phone number, email, just among council members, so that in case you wanted to give somebody a call or something like that, we would have that information. And, it, like I said, it would be kept, just among the council. So if you guys are okay with that, I can put something together and just send it out to you to fill in your info, and once it's all completed, I can shoot it back out to everybody. So you'll have it for reference and whatever, purposes. It's great if we're, doing like subcommittee planning and you sent an email, but you want to give a call or something like that. So if you guys are all okay with that, I could go ahead and finish that up and send it out, and we'll get it all filled in. Does that sound all right to everybody? Yeah, I'm seeing shaking heads. Okay. All right. Okay, so I'll go ahead and do that. And then topics for future meetings. Well, next month is our joint meeting, so that I think is pretty filled up. And December is our annual meeting, where we usually do our nominating committee vote and that sort of thing. So I'm not sure if we have time for a presentation. Kevin Bronson, do you have your hand up?
I do. Kevin Bronson, DDS. I just wanted to remind you, Patty, seeing that this is your first time being chair, that in the December meeting, you also pick the dates for 2025.
Great. Yep. Thank you. Put the calendar together for the, okay. Adrian, I see your hand up.
Thank you, Adrian Benjamin, council member. I brought this up last month at the end. So we used to go on field trips, and it was really helpful and informative. One month we went to Kevin Zingler's MARC program in Manchester and learned a lot we just toured his whole space, and it was fabulous. For people who aren't that familiar with group homes and day programs, it's a great way to see. It doesn't have to be his again, but someone's. We went to what's it called? This big center oh God, Walgreens,
Oh,
like
the Walgreens distribution plant
the
in
walls
Windsor,
where
Connecticut.
they have a commitment to hiring a third of their people have a disability, which is pretty amazing. We also went to the Hospital for Special Care's new autism program and did some tours. I know we can't do that every month, and I'm not suggesting that, but it would be good to put our heads together and think about visiting, learning more, seeing more. We all sort of know our own kids' situation, or our own setting situation, but to get a broader perspective for us, I think it would be great. That is all.
Thank you, Adrian. Patty, Council Chair. Pam, you have your hand.
Pam Donorama, council member. A few things. I don't know if everybody knows, Wynn resigned as ARC executive today. So that was a big disappointment. He has some health issues. So he submitted his resignation. So I know that there's going to be a search committee. Also, I don't know if we wanted to consider, doing a live meeting in December, considering it's the holidays. That was something I know we had talked about before. And just something to consider.
And bring food and cookies like we used to.
We have the most amazing ovens that were purchased by DDS that Commissioner Chef has yet to see. And now we're going to have them in 2 locations. As soon as we open up our new building in Hartford, there will also be a new commercial kitchen operating out of Hartford.
Wow.
We're producing over 500 meals a week with those ovens.
Wow.
What?
So you're luring us in, right, Pam?
That sounds amazing.
Yeah,
they are pretty. They are amazing.
Wow.
Well, thank you, Pam. Jordan, do you have your hand raised as well?
Yeah, Jordan Chef, Commissioner DDS. To Adrian's point, I don't remember if we've been to any of the supportive housing settings we've stood up, like the ones where up at Favar. I know there's some going in Hartford, but we now have them around the state. I think we have 6 or 7 operational, and I would love for you to see what I've been talking about in terms of the community built around an apartment building that is only 25% people with disabilities at a max, and just the sense of community and the beauty of the buildings and all of that. So I would suggest, now wintertime's harder, but I would still suggest we try and get out and see if you want to tour someplace. And I don't want to miss, I do need to see the ovens. I've been talking about seeing the ovens since Peter's retirement, and I need to go see the ovens. So, but I don't need you all to go with me. I can go visit Pam all on my own like a big boy. But if you guys want the cookies, then you have to come with me.
Let's go.
Well, Patty Silva, Council Chair. Pam, would that offer be open for the December meeting?
Sure. Pam Donorama, council member. My dog is barking.
December 19th. That's when the December meeting is. What do you guys think of that? Hey, I see Lisa has her hand up. Lisa, are you there?
I'm here. Can you guys hear me?
Yes.
I have 2 questions. One is, I think Adrian, you were just talking about the Hospital for Special Care. There's a new or something autism program. Do you guys know who's in charge of that, or how I can get some information about it?
Oh,
Pam.
Pam Donorama, council member. Lynn Riccio is retiring as well. She would be the person to contact. She's currently the CEO, but I don't know how long she has until her retirement, but she would be the person to contact for now.
Can you send me her information?
Sure.
Okay, great. And then along another route is, I don't know who to ask this, but maybe Jordan. We came across a bill a long time ago House Bill 23, blah, 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 that was talking about how maybe Pam can sort of bring it up a little bit better for us in terms of reimbursing the employers for those individuals, those companies that had more than 10% of their workforce with people with IDD. And it was quite a big reimbursement for the employers. But we found out that there's a loophole that the employers not only have to have more than 10% of their workforce of people with IDD, but they also had to have more than 50% of their products sold out of state. Now, we don't know where that came from. We've talked to a bunch of legislators and they don't know anything about it. Do you know anything about it?
Pam, if you want to go first.
Yep.
Well, I contacted Pam Donnarumma, council member. I contacted Economic Development because Damien and I were all excited, thinking, we can get reimbursed and stop being, in the hole. And we were informed that even though, we were hiring at competitive wages individuals with IDD, we did not qualify because 50% of our sales did not come from out of state. I tried to sell them on the fact that we have internet sales, but you had to show that 50%. And Damien, if I'm forgetting something, remind me. But it was pretty frustrating. And the legislation really doesn't make a whole lot of sense to us.
If I can just add, Jordan Chef, Commissioner, I circled around with Katie on this. Katie Rockburns, my chief of staff, COO. And I think there was good intentions in that bill, and somewhere along the line, in terms of it going from the starting point to the finish line, it got languaged in such a way that I don't know that anybody's really benefiting in any way. I can think of a few places in Connecticut that might be candidates, and I won't call them out, but there are, places here that ship a lot out of state, but to then also have 10% of your workforce meet that criteria and do that, I'm not aware of anybody participating in the program. So finding out who sponsored the bill and their intent and maybe trying to see if we can get that language change. I'm sorry, if you want to consider seeing that language change so that it actually has benefit, because I think it's also there's some language in there about whether you're for profit or not for profit, which impacts as well. So we need to see more, but I do think that while it was well intended, the outcomes have been disappointing, not just for you, Pam, but for anybody who's really looked at it.
Is there something that we can do, Jordan, to help with that? Because we seem to be putting a lot of pressure on, or some pressure on the legislators, and no one seems to know what's going on or where that bill came from and who added that at the very last minute. But it really defeats the purpose of the reason why it was set up in the first place. There isn't any company that can meet all the criteria that they've asked for, and we're leaving money on the table where people like Pam and Park and Favar, who are employing greater than 10% of those individuals with IDD, can't get this money to stay in business and keep our family members in a job. So I'm looking for any kind of help that I can do to support that change.
Jordan Chef, DDS Commissioner. Kevin, can you and Jill take a look and see if you can trace to the roots and point people in the right way?
Yeah, Kevin Bronson, DDS. Pam, do you happen to have the bill number off the top of your head? Or if you don't, I can look it up.
No.
Okay. All right. Yes, I can circle back.
Kevin, I'll send it to you.
Beautiful. Thank you.
Yep, no problem. Thank you for looking it up.
Okay, Patty Silva, Council Chair. Are you all set, Lisa?
Yep, thank you.
Yep. We have Diana with her hand up.
Thanks, Diana Minone, council member. I just wanted to say about the December meeting, if COVID isn't really bad, I think it's a great idea to get together, but I know from my own experience that our holidays have been ruined pretty much every year. So I tend to not go out too much before the holidays. Thanks.
Understood. Yes. Patty Silva, Council Chair. Pam, do you have the capability to host a Teams meeting at your location for those who, wouldn't be able to attend in person?
Damien's our tech guy.
We have done like virtual like walkthroughs and things just so you guys can get some measure of understanding of the equipment we have and what it's capable of. So yeah, we have done it. Obviously it's not as ideal as being in person, but yeah, I mean, just for us to introduce you to some of the stuff we have and how it works and how it really supports the individuals, I think we could do that.
Pam Donnarumma, Damien, I think they're referring to, can we, for those people that wanted to participate, virtually, in our new building, I believe that you can set something up where they can participate, correct?
Certainly, we've done that.
So we could host a council meeting there, and people who wanted to call in remotely could do that, just like we're doing now.
Yeah, that would work.
Okay. Okay, because we definitely want to have that option for everybody. All right. Do you guys want to take a vote or make a motion that we hold our December meeting at Pam's ovens? Does anybody want to make a motion?
I'll move that we try to meet in person at this time at Futures at the designated meeting time.
Okay, is there a second?
I'll second.
Okay, I think Michael had his hand up first. Thank you, Deirdre. All right. So all in favor of holding the December meeting at Futures? Say aye. Aye. Any opposed? There being none, looks like we will have our December meeting at Futures. And Christine, did you have a question?
Yes, I was just flipping my calendar to put it on my calendar. And I think our meeting was moved forward to the 12th because of the holidays.
Just one thing here.
So it's the 12th, not the 19th. Shannon says yes too. Okay.
Yeah, that's what yeah.
So it's the 12th, not the 19th. Pat.
Right. Yes. Okay, so it would be December 12th at 5 p.m. at Futures. Okay, so Wes, would you need to make the change for the meeting on the website?
For the location, I believe so.
Okay.
I will confirm how that has to work.
Yeah. Kevin, is there anything official we need to do other than that? Noticing or?
I'll check, but it might have to be considered a special meeting and you canceling the meeting on the 19th, if that makes sense.
We already went through that with the 19th. It's already been scheduled.
Then just the change of location.
It's just the location change.
Yep.
Okay. Very good. All right. Looking forward to it, Pam. Thank you. All right. So I think that's it for tonight. Did anybody have anything else? Oh, Jordan, Pam, is your hand a legacy? Okay, so then Jordan.
Damien beat me to the punch in the chat. Jordan Chef, Commissioner DDS. As we've been recording the meetings for the purposes of chronicling them, Damien, Wes, Kevin, and I can maybe meet offline to make sure that we can capture what we need to for an offsite meeting without having to go back to formal minutes, and especially with the bylaws change and all that. We also need, so we'll do that offline. I'm sure we can figure it out. But I just wanted to make mention of that.
Great, thank you. And Deirdre, you have your hand up?
Yes, I'm down here in Mystic, so I don't know where the ovens and Futures are.
158 Broad Street in Middletown.
Middletown. Okay, great. Thank you.
All right. Anybody else? I think we have some legacy hands up. Okay. Great. If that's it, then does somebody want to make a motion to adjourn?
Motion to adjourn.
I second the motion.
Okay, Adriana and then Pam. Okay, all in favor? Aye. Okay, we are adjourned. It is 6:33. Thank you, everybody. We had a pretty productive meeting and a great presentation. So we will see you all next month on November 21st at 5 p.m. at the joint meeting. All right. Thanks, everybody. Have a great night.
You too.
Have a
Bye-bye.
great weekend.